Good afternoon. We're letting a few more people in and then we'll get started. Welcome.
Okay, I have to see. Negotiation.
All right, it looks like we're getting some folks in. Andrea, do we need to wait on anything else or should we go ahead and get started?
No, you can go ahead.
All right, well, welcome everyone. Thanks for joining us for remaining engaged in academic global emergency medicine when travel is restricted. This is a didactic that is put on by AUS and GMA. And my name is Elizabeth DeVos and I'm here with Trish Henwood. And we are going to introduce to you today 3 faculty who are remaining engaged with their global work, even in these times of COVID when people haven't been able to travel. We're going to start our session today with presentations from 3 faculty. That'll take about the first half of our time. And then we'll spend the last 20 minutes or so in breakout groups or small group discussions to talk about what some of you may have been doing to remain engaged in global EM and also to ask questions of our speakers. So thank you for joining us. It's my pleasure to introduce to you today our 3 speakers. I'll give you each of their bios, and then we'll ask our first speaker to get started. Our first speaker will be Dr. Megan Rybarczyk. She received her medical degree from the Johns Hopkins University School of Medicine and completed residency training in EM at Boston Medical Center. She served her final year there as chief resident and then completed the Global EM Fellowship at Harvard and Brigham and at Brigham and Women's Hospital. She had a focus on EM program development and emergency care systems development. Her research and academic interests are currently focused on EM education and training, and particularly in low resource settings. She's currently an assistant professor of clinical emergency medicine at the University of Pennsylvania Perelman School of Medicine and is fellowship director of the Penn Global EM Fellowship. I'll go ahead and introduce our other speakers and then I'll let them each follow one after another. Our second speaker is Dr. Grace Wanjiku, and she's an assistant professor of emergency medicine at Brown University. Her research interests include creation and evaluation of point-of-care ultrasound training programs in low resource areas. She's been involved with nationwide focused training programs in Kenya and has organized short focused courses for the AFEM conferences in Kenya, Egypt, and Rwanda. And Dr. Andrea Rivas-Dreyfus is Ultrasound Global Health Director at Highland Hospital and co-founder of Ondas de Latin America. Her international work is focused throughout Latin America, where she created the first EM ultrasound fellowship in her native country of Peru. She received her MD from Stanford School of Medicine, an MPH from the University of California at Berkeley, and did her residency and fellowship at Highland Hospital in Oakland, California. And now I'll ask Dr. Rybarczyk to go ahead and share her screen and tell us about what she's been working on.
Wonderful. Thank you, Dr. DeVos, and thank you, Dr. Henwood, as well, too, for moderating the session and for inviting me to come and speak. It's an honor to be among this esteemed group to talk about how to remain engaged in global EM when travel is restricted. So as Dr. DeVos said, my name is Megan Rybarczyk. I'm currently an assistant professor of clinical emergency medicine at UPenn, and I'm the Global Emergency Medicine Fellowship Director. I am also the academic lead for the Certification Program in Emergency Medicine, or CPEM, and that's one of my main projects right now, and that's what I'll be talking about today, some lessons learned from how we've been conducting this program over the last year. All right, so to talk a little bit more about this program. This program, CPEM, was an independent course that was developed by an international group of faculty several years ago, and it was initially developed for physicians in Karachi, Pakistan. And the goal was to create a program that would help develop emergency care systems in the area. It's a medium duration, so 1 year EM training program that's broken into 12 blocks, and it's designed to bridge the gap as formal emergency medicine training programs are built up within the country. So as of right now, there are just under 10 formal residency programs in emergency medicine throughout Pakistan, and their programs are 5 years long. So as you can imagine, it's going to take quite a few years to develop a cohort of emergency medicine physicians there. And so the ask from our partners on the ground there was to design something that would be medium duration and help individuals build up skills in the meantime and bridge that gap. And so what was initially designed a couple years ago was kind of a two-armed program. One is CPEM Clinical, or what we called CPEM-C. And this was for folks at the host institution where we were applying the program at the Indus Hospital, which is a free for cost or free for service um, uh, uh, health system within or throughout Pakistan with their main flagship hospital in Karachi. And this was where the program was hosted. And so these folks were involved in CPEM-C, or our clinical portion of the program, where they received not only the academic portion of the program, which was our weekly conference sessions, but also bedside mentorship on a daily basis. And then we also, in the efforts to help build up the emergency care systems in the area, invited individuals from other institutions across Karachi to be involved in the program as well too. But they were only able to be involved in the academic portion of the program, and so that's CPEM-D or CPEM didactic. Those are once a week academic sessions, about 5 hours, that were comprised of a variety of sessions, which I'll talk about in a minute. But the purpose of that was really to bring other individuals from other institutions across the city so that there was a diversity of experiences that could be learned from different case mixes, different setups of different institutions, and then also to help build up relationships and collaborations across Karachi, which is essential when you're building up emergency care systems. And this program is conducted by international faculty from all over the world that have experience in both high and low resource settings in teaching emergency medicine. So we had folks from the UK, Malawi, South Africa, the US, Australia that have been involved as faculty with the program to date. And really the objectives of this program were, one, to improve emergency care delivery, to encourage specialization. As I mentioned, we do not want to supersede any specialization pathways in the country, but just wanting to bridge the gap while individuals are getting involved in those programs. To foster support for the development of the system, as I mentioned, intentionally designed to help develop collaborations across the area. And then also to improve job satisfaction, wellness, and employee retention, specifically within the Indus Health system. And then again, to develop those collaborations. And so this was how the program was designed initially a couple of years ago, pre-pandemic. And again, really heavily involving international faculty face-to-face throughout all 12 blocks throughout the year, not only administering the academic curriculum, but also providing bedside mentorship on cases and things like that at the Indus Hospital. And the purpose of, or the way that the academic sessions were designed were to provide multimodal learning. And so the academic sessions are comprised of didactics, small groups, specialty topic sessions on things like pain management and triage, simulations, workshops, sessions that were flipped classrooms so that the trainees themselves were also engaged with the material in a different way. Question-based review with multiple choice questions, case review, journal club, so on and so forth. So really trying to provide a multimodal learning approach and have participants engage with the material in a variety of ways. More specifically, a few of our on-the-ground learning strategies were, again, were the bedside mentorship. So visiting faculty would come in, be at the bedside with individuals on days that we weren't having the academic program, and provide mentorship on cases, help them log different cases and procedures, and then be engaged with simulation with a variety of both high fidelity and low fidelity simulation materials, phantom models. Also doing bedside ultrasound teaching, which was a novel concept that was introduced in the Indus Hospital Emergency Department when we started this program. So developing really that point of care ultrasound, as well as engaging with the radiology department to see how we could potentially build up an emergency ultrasound program there as well. And so that has really been what had been going on up until the pandemic. we also, in terms of thinking about transitioning during the pandemic, had already incorporated several virtual learning strategies. And I think that's probably one of my first key takeaways here, is that we had already incorporated a lot of virtual learning strategies before the pandemic. So it was a fairly easy transition to continue and expand those virtual learning strategies once COVID-19 hit. And so this is just an example of all the things that we had been using both pre and post, or post the start of COVID-19. And I've highlighted here the ones in red, the ones that we really added on afterwards to help enhance the virtual learning strategies, or that were expanded because of our greater reliance on virtual learning strategies once COVID-19 hit. I've also added on here, just for your reference as well, to the ones that we've actually needed to allocate some of the budget for, in terms of thinking about what's free and what you might want to incorporate in your budget. But these were all the different virtual learning strategies that we've engaged with the program. So some organizational tools that I would recommend: we use Dropbox to really house a lot of the larger, bulkier material, just because we have a larger Dropbox where you can put a lot of stuff. After transitioning to a fully virtual curriculum, we relied a lot on Google Classroom, because you can create assignments and ensure that individuals are keeping up with milestones and performing certain tasks on Google Classroom, which is very useful. Google Drive as well too, just for storing things. When thinking about content, when we went from an in-person curriculum to virtual curriculum, we transitioned all of the didactics to recorded lectures and incorporated that in with Edpuzzle. Edpuzzle allows you to space multiple choice questions throughout your recorded lecture, so you're ensuring that people are actually watching the recorded lectures. And so putting those two together has helped us then move all the didactics to an asynchronous learning curriculum, and then allow a more efficient time in person when we have our Zoom meetings once a week, to really engage with the material through discussion and small groups and simulation and cases, rather than spending that time to do didactics. And that, I think, was one of our biggest transitions. Again, for content, using things like Poll Everywhere or Kahoot to really make things interactive, and then engaging with folks with different videos, links to different content that's already online. So things like Crackcast EM, all the different podcasts and blogs that are out there in EM. There's a lot of content that's already out there, already developed. You don't really need to kind of reinvent the wheel and make a lot of this from scratch. I'm thinking about all the AFEM lecture that are out there in the lecture bank. So there's a lot that's already out there that you can adapt to your program as well. Just for like feedback, logs, attendance, using things like Google Forms. For evaluations, Socrative, which is a great way of doing written examinations online, that we used an account that was already through the Indus Hospital to do that. We did oral examinations through Zoom room breakouts, using RedCap for anything that we were going to potentially use for publication, for surveys and things like that. Again, as I mentioned before, all of our weekly sessions became interactive on Zoom, and so we were using that. And then we relied a lot more heavily too on graduates from the program and local leaders to really help engage the trainees with some of that on face-to-face, hands-on content that really couldn't be delivered virtually through Zoom. So when we were talking about procedure labs and ultrasound as well. And then for simulation, which has been one of the most challenging things to transition, we have continued our practice of running intermittent cases over WhatsApp. You can see an example of a screenshot here on how we've been doing that. We started that from the very beginning of the program, but kind of beefing that up a little bit, just to allow more case-based discussions, even not during the conference session times. And then we bought a subscription to Full Code, which is a medical simulation application where we've been running kind of group simulations as well since the pandemic. So I'll kind of go quickly through, how have we done with all that? So we've had 2 cohorts so far, one that was entirely pre-COVID, and then this last year we had a kind of a 7-month break right in the middle of the curriculum and kind of finished then up virtually afterwards. And as you can see, we had a good increase in our pre and post examination scores, both on match questions as well as overall scores. All of the participants had improved clinical scores, and we had a 70+% graduation rate despite the pandemic. So really, really good outcomes despite the large 7-month break that we had when transitioning to the virtual curriculum and because of COVID, and then also in transitioning to completely virtual. So as I mentioned, I guess just a couple challenges that we encountered. Some issues with time zones. Obviously, Karachi is about 9 to 10 hours difference depending on the time of year. And so we've really tried to strategize, as I said, optimizing the timing of those sessions, making sure that we can engage both the instructors that are signing up to do the sessions as well as the students that are there to ensure that we really make that time as short and efficient as possible, that in-person time, and do as much asynchronous learning as we can to try to keep people really engaged. Because of the bringing down of our budget from not having in-person faculty quite as much, we've been able to invest in resources to help with connectivity, especially on the ground. So that's been a great transition there, but still some issues with connectivity for the folks on the ground. And then really just trying to strategize better ways to do the hands-on components. And from there, I said, we've really worked on engaging graduates from the program and content experts on the ground to really be engaged in those sessions as well. So we're looking forward to a new cohort number 3, and starting at the end of June and July this year. We're also hopefully going to include a cohort from Bangladesh as well too, to really make this kind of a CPIM global sort of program. And we're looking forward to having faculty and teachers engaged in that. So if you're interested in the program, let me know. I will say, there's been a lot that has not really worked out well, obviously because of COVID and a lot of negative effects from COVID. But I think when we think about a global EM and this paradigm shift that has really happened to more remote and virtual engagement with our partners, I think this is a great step in terms of decolonizing global health. And it's a great way, I think, to really build up leadership in different areas of the world, in areas where EM is still developing as a specialty, and I think really building up our virtual resources and our ways of engaging that way. So I'm really excited for how things are moving forward in global EM, and I'm really excited to be a part of that, and honored to be working with all of you to make that happen and help advance the specialty worldwide. So thank you so much. I'm happy to answer during any of the small group sessions a little more questions about our program. And if you're interested in the program, let me know, or interested in the fellowship program here at Penn, you can email me or the fellowship here and follow us on Twitter. So thank you so much.
Fantastic. Thank you, Dr. Barczyk. Dr. Wanjiku will get her screen ready, and we'll hear from her work in Kenya as well. Go ahead and unmute. There you go.
Okay, I hope that looks okay. Thank you so much, Dr. DeVos and Dr. Henwood, for arranging this and for your invitation. I'm really honored to be here. I'm going to be talking once again on the same topic, but this time I'll be focusing on my work in Kenya. I am in the Global Health Division at Brown University, and my particular interests are in developing point-of-care ultrasound training programs and also evaluating them in low resource settings. And I am primarily involved in Kenya, where I am from. And so I just wanted to just make sure that I can advance this, okay. To talk about my experiences with our point of care ultrasound training program. So I work with an organization called Emergency Medicine Kenya Foundation. I started working with them in 2015. So some of these strategies, as Megan was talking about, are things that we were starting to think about and create even way before the pandemic hit. So when I joined Emergency Medicine Kenya Foundation, they had this training program that basically we drew our trainees from all across the country, as you can see from that map. And since 2015 till now, we've had multiple challenges, but we've been able to interface with more than 150 trainees from over 60 facilities. And these are all different sizes, some small facilities, to other bigger facilities across the country. And when we started working, we were working with a faith-based organization that is the one that approached us, and they said, we want our practitioners to be trained in point of care ultrasound. And so the people we worked with were medical officers. So medical officers are people who've been trained, or individuals who've gone through medical school. They've done a year of internship, but they're considered to be general practitioners. So these are GPs. We work with clinical officers who are the equivalent of physician assistants here in the US, also working with nurses and radiographers. So these are, primarily the people who are out there providing care in outpatient centers and emergency care centers. And so the organization we worked with would identify the people that they want to be trained. They would give us the names of the trainees. And what we would do is that we provided a multimedia training manual to them. We would send it to them pre-training so they can read it, they can watch the videos and take a test, an MCQ test that they were required to pass before coming into the city to participate on the hands-on. So when they come into the city, it's mostly just 2 to 3 days of just hands-on point of care ultrasound learning. And this is primarily the EFAST exam and focused obstetrics. So it's kind of a basic training program that we wanted, that we saw that it would cover most of the issues that they see in their emergency care centers. So we would do this 2 to 3 days, hands-on training. And then we partnered with an organization that actually donated ultrasound machines. So our trainees would get ultrasound machines and go back to their facilities with them. The issue is that when we started, there were only 3 of us who were the core trainers for this program. And we had, additional people that we would get who would help us with the hands-on. But the challenge is that once the trainees then go back to their facilities, we wouldn't see them again until 3 to 4 months later, when we did this thing called, I would call the ultrasound safari, which was really fun. I did it when I was a 4th year, that you get in the car and you travel to these facilities. You go see how your trainees are doing, kind of see what challenges they're having. And then you basically do an OSCE with them. So it's just at that time, evaluate them, have them scan and grade them, see how they're doing, kind of evaluate them. And so at that time, if you feel like, if they don't meet the milestones they need to meet, they would be invited back into the city 3 to 4 months after that to have refresher training. And so the process would repeat itself. They have initial training and then they have as many refreshers as they need to become competent until they're deemed to be competent, and they would get a certificate of competence. And so that's the way the program is structured. And as you can see, we then did an evaluation on this article. The article came out in 2018, but this data was from 2016, 2015. And basically what we saw is what you would kind of expect. And the first table here, if I can just point out that when looking at image quality scores, we found that the more training sessions someone had, the better they did with their image quality, which makes sense. If you've had initial training and then you've had 1 refresher, you've had 2 refreshers, if you look at how you're doing with your EFAST, you do better the more sessions you've been exposed to for training. And this was across the board with thoracic, cardiac, and obstetrics. The other thing that we found, which was its relevance to this, is that we found that the more time elapses in between your training sessions. So it would happen that sometimes when we go on the ultrasound safari, maybe one of our trainees is on leave or they're not in the facility at that time. So we miss them and we don't see them again until 6 months later when we invite them into the city, or even longer than that. And the more time elapses in between interfacing with them, the worse they do. So you can see that if you were trained less than 3 months ago, you do better. But if you last saw you more than six months ago, then the scores are worse. And so at that time, we were already starting to grapple with how do we increase the amount of time that we interface with our trainees. So we started working with this organization called Project ECHO. And what Project ECHO is, ECHO, actually I should have put it all in capital letters because it stands for Extension for Community Health Outcomes. And it was started at the University of New Mexico. And the guy who started it is a hepatologist. He helps to deal with hepatitis C, hepatitis B. And what they found in New Mexico was that people were waiting for a long time, waiting in line to see this hepatologist at University of New Mexico. So what they did was that they created a way for the specialist to get onto Zoom, basically to do web conferences with providers in outlying clinics, and they would run cases and they would kind of form a community that discusses what the state of the evidence is and management strategies. And this basically would allow the practitioners to treat these Hep C patients at their own home facilities instead of having them wait in line forever to go to UNM to see the specialist. So it's a way of kind of democratizing knowledge. It's not telemedicine in terms of, it's not the doctor and the patient, it's basically the specialist creating capacity for the healthcare providers out there so that they can in turn, reach more patients out there. So we thought that this model works for us because, it's not really patients that we have out there. We have trainees who are out there all across the country. There's a huge geographical divide. We have very few trainers to begin with. And we want to kind of disseminate this specialist knowledge so that they can get good at doing point of care ultrasound. And in the end, they'll be deemed as competent. They will not need us to be over, their shoulders telling them, do this with a probe and move it this way. So that was the goal. And that we basically would get on Zoom every 2 weeks, do a very short didactic, maybe 10 to 15 minutes, and then do the flipped classroom where they would present cases to us. And we had a formal presentation template, present cases, show the ultrasound images that they looked at, and kind of discuss, like, maybe next time you can try do this, and then we would also deal with management. After you see this, what do you do? If you see free fluid after a trauma, what do you do? What challenges do you have in terms of referring them for further care? So that is the way we decided to go. And, so with Project Echo, basically these 2-week sessions are known as tele-echo or tele-echo clinics. And so for this pilot that we did, this was once again in 2018, pre-pandemic, was that we took people who had initially been trained. So these are people who've been undergone their first training, and their clinics are all across the country. And, we started working with them to do this 2-week telementoring sessions. And so the challenges that we had with this, are multiple, as you can imagine. There was difficulty with accessing the internet. And this is when, they tried to use the computer either at work or using the computer at home, connectivity problems. And we kind of got around this by just having them use their smartphones. So smartphones are the way in which most Kenyans access the internet anyway. And so they get prepaid cards, or you pay for time. You basically pay AT&T or Verizon to get a specified amount of internet access that you can use to make your calls or to get onto the internet. The issue is that internet access through your phone is expensive. And so we, during our pilot, had to provide funding, get a little bit of a pot of money and it's $10 to $20 per month to allow them to come and hop on Zoom for 2 hours every 2 weeks. And that's what it took, basically, to get over the hurdle of cost. Because most of these people, they don't get paid particularly well. They're working in small clinics. And so it can be prohibitive financially. We used Zoom. So Project Echo encourages the use of Zoom. And we found that it performs pretty well in areas of low bandwidth in rural Kenya. But still, there were disruptions where the calls would be dropped. We used WhatsApp for messaging. Initially, when we started, to send the Zoom link, we would send it to people's emails. And we found that this just does not work. And so any way we wanted to send any kind of communication had to be through WhatsApp. Despite all of this, there were other challenges outside of our own training program in that a lot of our trainees did not get protected time. They're out there, they're working in small clinics, they're very busy, they don't have protected time. And actually, when we started with this program, we actually would run it on Friday evening at 5 p.m. after work. So you can imagine how challenging that would be in terms of trying to find a time that works for people. They want to learn, they want to be better, but they don't have protected time during their clinical work hours. And they're not in an academic medical institution, they're just kind of out there in their little clinics. So that was tough. However, most of the trainees felt that this material was relevant to them. It was clear, it was well presented. It's something that they desired and wanted to have. And, they said that they increased their confidence with ultrasound scanning. which for us, means a lot because, for you to be out there scanning, you have to be confident enough that you know what you're doing, because the more confident you are, the more you scan, and the more you scan, the better you get. There's really, with point of care ultrasound, there's no way around that. You have to scan more to be better or to get better. So, that's my experience with the rural training program, and I'm happy to take questions and, answer what that is. And I think that, this was all pre-pandemic, and, with COVID-19, I think it just came and kind of exacerbated the issues that we had, because, you're dealing with a geographical divide. Right now, we're not able to travel, we're not able to go there. But even in times when I was in Kenya, I have clinics in places that, would take 5 to 6 hours to drive to, and longer during rainy season when, when the bridges have been washed away. And so, we were dealing with the same issues, just I think COVID-19 exacerbated them. We can discuss that further. My other experience was with arranging the AFEM conference. So the African Federation of Emergency Medicine. Every 2 years we do this conference. It's great. It's amazing. It's like the best conference. I love it. But then in 2020, everything was converted to virtual, and we were tasked with creating a one-day point of care ultrasound workshop. It is hard for people who teach point of care ultrasound to tell them, okay, you have to go online and teach everything online, because there's really nothing that replaces being there and holding the probe and guiding someone on how to do it. But, we pulled it off. We had, subject matter specialists from the US, from Canada, from, presenters from Europe, and we just did recorded lectures, short didactics. We tried to keep them as short as we could. And we kind of, in between them, we would have, short videos, 5 minutes, that demonstrated technique. So we tried best we could to demonstrate the technique, to give short didactics, and then talk, and on the chat and answer people's questions on the chat. The time difference was challenging, because once we put all the lectures together, we had the full day planned out, but I had to wake up at 2 a.m., to be on and to be live, because then we have to be on the chat answering people's questions. But still, despite those challenges, I feel like we were able to reach more people. People were highly engaged. They were asking questions, sending articles, discussing the data, in ways that I felt that even with the in-person, we really didn't get that much engagement. And also the online platform that we used allowed us to just record everything, and people would go back, so I was still getting questions a week or 2 weeks after that you'd get onto and discuss. So, despite the challenges, I think the engagement, we were able to reach more people, engage with more people. And I'm happy to talk more about that and kind of show some demonstrations of that later. And yeah, that's it. Thank you.
Thank you so much, Dr. Wanjiku. Dr. Dreyfus, if you'll get your slides ready as well, please. I think since we have this size group, we'll have a short discussion all in one group after she's finished with her slides.
Okay, am I all set? Great. Thank you, Dr. DeVos and Dr. Henwood, for inviting me to be part of this panel. And I'm an ER doctor from Peru originally, currently working in Oakland, California at Highland Hospital. And a little bit of my presentation is going to be discussing our already established pre-COVID multimodal ultrasound fellowship that we set up in Peru, and a little bit of both the fourth innovation that we were faced with during the COVID pandemic, both in the educational component as well as the clinical impact that our amazing fellows continue to have every day. We just finished actually our journal club a few minutes before this. Let's see, I don't know why I can't go next one. There we go. So a little bit of the agenda, I already sort of mentioned it. I'll describe to you our ongoing ultrasound fellowship program that we're currently working on. Our third class is a one-year fellowship program in Peru, although this year we expanded it to Costa Rica as well, prior to knowing that COVID was going to be a thing, of course. And then we'll discuss some of the COVID innovations, future areas of investigation regarding that COVID innovation, and then the lessons learned. So just to tell you very little about emergency medicine in Peru and how this fellowship came about 3 years ago. So emergency medicine has been a recognized specialty in Peru since 1993. So it's perhaps a little different in stages from other places where we help develop emergency medicine further. So with that said, and my focus is on ultrasound education, Back in 2001, for whatever reason, the Ministry of Health had a decree that every single higher level emergency department needed to have an ultrasound machine accessible to them. That doesn't necessarily mean that every single emergency department had one, but there was a push for that. With that, no education actually came. And that's why about 7 years ago, when we started this relationship with their public hospitals, we realized, they have the tools, which back then it was the hardest thing to get. How do we have some of the knowledge? Let's work together and develop this educational program. So we created a partnership initially just with one hospital in Lima, one of their public biggest hospitals, Hospital 2 de Mayo, which subsequently throughout the years of our fellowship developing has grown to different, not only hospitals within Lima, but also different cities and towns within Peru, and lately this year in a different country in Latin America. And I think this is mostly because our project from the beginning, pre-pandemic, as I mentioned, used this multimodal way of educating that has really proven to us to be very sustainable. So I'm just gonna go very quickly through kind of like our way of how do we teach ultrasound, how do we create leaders, how do we foster further growth within each of our fellows. And I think that just ends up becoming this beautiful snowball effect that just spreads all throughout. And this, particularly this year of the pandemic, has been evidence of that. So we have 4 components: the hands-on education, which is probably like the most typical one, pre-COVID things, and how we do a little bit of other education here in the United States, right, when we're in person. The telemedicine component, which I'll discuss a little more. That's going to be both synchronous and asynchronous. Then our quality review, which is weekly so absolutely all of the scans that our fellows collect weekly are uploaded, and we go through all of those images Thursdays on a really fun 3-4 hour session. And then joint with that, our journal club that we do on a weekly basis. And I think part of the reason that this we didn't really had to reset when we were one of those programs that, given that we were already reliant on telemedicine, on Zoom, and all of that, we didn't really have to teach them how to adapt or teach ourselves how to adapt. But it did allow us to grow from that for sure. So the hands-on education component. So we did have to adapt a little bit to that this year. So at the beginning of our fellowship year, our 3 to now 5 fellows yearly will do a 2-week ultrasound bootcamp. Back pre-COVID, we would fly down there, join together, have more like, lecture format. And then in the afternoons, we would just scan together in the hospital. How we adapted to that this year was that we did all of the Zoom formal lectures like remote. And then the wonderful thing is that because we had already had fellows train 2 years ago, they were able to do the scanning sessions with them in the afternoons. So they did get the in-person component, but again, it's I think, and this is again, preaching to the choir, is the teach the trainer, teach the leader, because we were already invested that 3 years ago, it didn't really matter that myself and my partner, David Martin, were not physically there. With that said, because, and we'll discuss a little further, because we do have the synchronous telemedicine component, when they had questions, we were always available. And this was even pre-COVID, but probably now during COVID, we're using it more regularly through WhatsApp, or which then would allow us to connect on our React session. This is just the system that we use, and we would be able to do that with them live. The 1-month ultrasound rotation in the United States, unfortunately, we have not been able to restart that again, but I'm hoping as more of our colleagues are fully vaccinated, that's something that, in discussion with both hospital systems, we're hoping it's gonna become a thing, hopefully. So this is a little bit of the telemedicine component that I sort of hinted at on the last slide. So this is me. And this is Arun Nag, the ultrasound director at Highland. And this is, I think, 3 years ago when we were first setting it up. And just, he is able, even though he's in San Francisco, to look at that live image of what we're scanning, and also at my fellow at his hand. And therefore, when you guys were discussing some of the issues of doing that, and of course, it's a little bit more challenging if it's the first time you're ever grabbing an ultrasound. But for people on the fellowship level, it's actually not that challenging. It may take a little more time than in person, but once you use it on a regular basis, and this year we've actually been doing it at least once a week with our Costa Rica fellow, that until a month ago, we had never actually met in person. My colleague David Martin was able to go to Costa Rica last month, which was wonderful. And it was so great that, because we had this in place, it was just a matter of just now, let's just do procedures with her. They did like 5 femoral blocks and other really fun regional anesthesia. And then this little dot, for those of you that are not familiar with ultrasound, it's like both the Arun, for example, can be able to be like, what is this? And my little dot, which I don't even, is right here. You can indicate like, I want you to move your probe this way. So technology, again, has allowed innovation to happen. And I do not take any of this credit. I'm just the lucky person that gets to use the technology that has grown. Similarly, SonoClipShare started by an ER doctor, Ben Smith, a few years ago. We were one of the few pilot programs that started using it. Also has allowed for ultrasound education. One of the biggest problems for global health is like, where do I upload the data? We were doing, I think prior to this, Google Docs. It was too clunky and confusing. This is a very easy to use software, free for now, where our fellows can upload absolutely all of their scans. And as I mentioned, weekly we review with them at the same time. And there's a little bit of an example. So this was 2 years ago. And unfortunately, I think I blocked it. It's not showing that well, so I apologize. But essentially just through Zoom, you can see what they're talking about, how it plays. You guys now at this point know how to use Zoom. When we showed this in presentation a few years ago, it blew people's mind, but it's just it's synchronous on already uploaded video reviews. So we graduated our first class of fellows in July 2019. Those were all fellows in Lima. To the date, we've graduated now 7 emergency medicine physicians that are now fellowship trained. And this year we started training, we delayed it started in November, 5 new fellows. So in our second year, which was, I guess, 2020, we were able to expand to new sites, including the Amazon rainforest and the Peruvian highlands in Iquitos and Cusco. And this is just an example of our fellows they're not only teaching their own residents or colleagues, but they have continued, even post-COVID, to invite it to national conferences where they are, teaching applications such as regional pain anesthesia, management in cardiac arrest, and ultrasound usage in both Peruvian, Latin American conference. And for example, recently they just presented at AIUM some of the stuff that I will feature in the next few slides. Additionally, they created the first annual ultrasound procedural course for all emergency medicine residents in Peru. So there was like 40 emergency medicine residents that would come to 12 de Mayo pre-COVID. After COVID hit, it didn't matter. They started doing a monthly Zoom session where they would continue to give this education for now residents that were outside of Lima, perhaps, or their own hospitals. They've also started, which right now currently is at a pause, but they started the first elective ultrasound rotation for emergency medicine residents nationwide. And pre-COVID, there were people coming from, again, more rural areas to rotate with them. They're very active in free online medical education, which makes me so proud. And I think this has continued to grow through COVID, right? Because I think that's how they are collaborating and meeting other people doing interesting ultrasound education and research in low resource setting Spanish-speaking places. These are just some of those examples. This is a really great example of, again, innovation and how to do your own pericardiocentesis model with a pig's heart. It's really great. So now what I'm going to do is going to feature 2 projects that our fellows did during the COVID pandemic that really took off and got not only national recognition, but international recognition. So unfortunately, and you guys might have heard this, Iquitos, all of the Amazonian rainforest back in April, March was one of the highest case fatality ratios in the entire region. When that happened, we actually had a fellow that was training in Iquitos. And so she suddenly had to, Dr. Jeffrey Vargas had to think about what are ways that I can try to help, I can try to help my patients during this pandemic. So, so public health specialists in Iquitos estimated that about 70 to 80% of the population were infected with COVID back in April, which is crazy, right? It was the one place that they were like, oh, maybe we had herd immunity. So she realized quickly early on that hospitals were quickly running out of resources for treating people. And so she started trying to figure out innovative ways to address this. And she started going to patients' homes like that had already tested positive for COVID and try to use the ultrasound. And this is very early in the pandemic when we didn't know much about it. Try to decide if using ultrasound could help her determine who was gonna do worse or better, who needed oxygen or not, and as well as treatment guidelines. So the Ministry of Health at that time, this came out with an algorithm and they were like, you give all of these meds that now most of them we know don't work to some people and not to some other people based on just vital signs. So she was trying to understand whether she could be a little bit smarter about it. Why is this not going the next? Oh, there we go. So as I mentioned, her objective was early identification of patients with worsening clinical status who might benefit from early treatment and or hospitalization. And as you imagine, in many places, but in Peru in particular, and in Iquitos, most of these patients didn't have access to chest x-rays. The hospital system had essentially collapsed. Most of the doctors and nurses got COVID in this region. So it was a state of let's try to be innovative in how we manage this. So Dr. Vargas, trying to limit the patients coming to the hospital, would come to their homes on a daily basis and check on them and use ultrasound and recorded all of these images to try to further understand this disease. And so these are some of the images that she got. And again, you know, she would keep this beautiful log on the 70 patients that she was visiting and how their lungs would look and how they would do clinically. And so, you know, this is just an example of patients who underwent serial pulmonary ultrasounds, and you can see that they would either improve or not improve. These are just like the B lines, the thickening of the pleura right here. Let's see. And just the same pattern. So after having some issues right here. There we go. So similar to other groups that were utilizing ultrasound of the lungs in evaluating patients with coronavirus, she looked at the literature, discussed it with us and a set of other ultrasound faculty at Highland to see whether we could try to adopt a score in determining how sick a patient was. And so we decided on 12 areas of the lung that we would scan, 6 on one and 6 on the other. And then we essentially gave it a score depending on how much artifact or B lines she would see. So a normal lung, you would see a decent amount of A lines and good pleural sliding, and that would give you the lowest number. And the most concerning findings would be like pulmonary consolidations would give you 3. So furthermore, so if you look at how many sides in the lung that we were scanning, it would be the healthy lung would be 0 points and the sick lung would be 36 points. So Dr. Vargas performed these serial examinations in those 70 patients in Iquitos, and based on this, she observed them, and so she knew how they were doing and decided that almost all patients who subsequently actually needed oxygen, which they ran out in the region, so it was really important to know who may or not get there, had initial lung ultrasounds of scores greater than 16. So with that information that she gathered, our fellow at the same time in Lima, which the first wave hit a little later, try to come up with a stratification tool in Lima that would hopefully help him triage and therefore limit the amount of resources that we're utilizing. So Lima, just a matter of a few months later, had their really severe COVID wave. And again, their hospital systems there collapsed, similar to in Iquitos. So
Dr. Dreyfus, thank you so much for presenting your first research project. And I think another one we're going to have to save for conversation later with you.
Yeah.
You guys have been so productive during this time of COVID, and I really want to thank all of our speakers for sharing with us how you kept your programs going and how you've used virtual ultrasound training in different ways and other virtual training in your classrooms. Unfortunately, I think we're close to the end of our time, but if there's any burning questions, we can take them now or put them in the chat, and we can definitely connect you to our speakers.
I appreciate the see one, do one, teach one. I think that the virtual context has led to more of that happening in emergency medicine, and the see one in this context might have been happening on Zoom instead of at the patient's bedside. A quick question for, I think for Dr. Wanjuku and Rybarczyk. Obviously, Dr. Dreyfus, your program, I think in part because of the context of the time zone being a major consideration in some of these programs. And it sounds like you guys have really grown the efforts, and all of these were having a telemedicine component before COVID. How have the others in different significant time zone areas had the feeling of the strength or the challenge associated with the remote need? For Grace or Megan?
I think for us, the time, the time challenges means that we're really not, we have a harder time with the synchronous part of it. It's hard for, if someone is at the bedside at, 8 a.m. or 9 a.m., it's almost like 1 a.m. or 2 a.m. in the US. And so it's hard for them to be able to get onto WhatsApp and be like, okay, Grace, can you look at what I'm looking at? So that part of it has been hard. In terms of the image review we do is after the fact. So we're still trying to find out what's the best way to do with that. And I think the more we train people and we get more people who are competent, who are in Kenya, they can kind of be on call during those hours when someone in the US or Canada or Europe cannot be on the phone.
And Megan, have you found the same? I think that the time zone considerations sort of play into how challenging some of these considerations have been.
Yeah, exactly. I think that's been one of our biggest challenges. For the program that I'm engaged with, we don't really do any like direct clinical care or that kind of time sensitive need to like review images or anything like that. So there's a little bit of flexibility there, but I think a couple of things that have really helped us is we've just really tried to optimize when folks who are really engaged with our program in terms of instructors are available versus when the trainees are available there. And so we found kind of a good compromise in terms of really early for us here, like on the East Coast, and then kind of late afternoon, early evening there is a good time, just because like dinner is usually eaten a little bit later. And so we're able to kind of get that in right before that. And then also engaging individuals from other countries in the world. So we have a lot of partners who have worked with our program in like Australia and even in different places in Africa as well too. And so they're at a little bit of a different time zone. And so just being a little bit flexible as to when we can optimize the time for both the instructors and the trainees on the ground. So not necessarily having like one consistent time every time, but being a little bit flexible with those who are engaged in the program. So.
Fantastic. Yeah, I've definitely found similar. How about we probably have time for one more question from the audience. Any other questions out there? I mean, we don't have a ton of time, but I want to make sure that we have if anyone has questions, you have a chance. Well, thank everyone for both joining the session and to our presenters. I think amazing work in showing both the challenges, but really the strength and some of the concept of how COVID has been quite disruptive to the global work we're doing, but almost in a positive way in some contexts in, I think, empowering a lot of local leadership and taking the seeds that have been planted over time and letting those grow with a lot of remote support. So kudos to you all for your fantastic work, and thank you for presenting today.
Thank you.
all.
Thank you
Thank
for
you.
organizing. Appreciate it.
Thank you to the program committee and the SAEM staff as well for all the work you did to make this possible today.
Take care, everyone.